Okay, so yesterday we have discussed about the adrenal, no, the hormones that are being produced by the adrenal gland. So to recap, the different hormones that are being produced by the different zones of the adrenal gland. We'll start here with the different areas or the different zones of the adrenal gland. So in this case, or in this diagram, we have here the diagram of the adrenal gland with the different zones of the adrenal cortex. So for the adrenal cortex, now again from without inward, the three zones of the adrenal gland are the zona glomerulosa, now we have the fasciculata, and the reticularis. For the hormones that are produced by the glomerulosa, so basically here we have the mineralocorticoids. The prototype or the representative mineralocorticoid or the most potent mineralocorticoid in the body is the aldosterone. So when we say mineralocorticoids, these are hormones that will regulate the mineral balance. When you say mineral, uh, that will refer to the salt, the salt and the water balance in the body. We also have the fasciculata. The fasciculata will produce the glucocorticoids. So when we say glucocorticoids, those are the hormones that will regulate the glucose metabolism, or those are also the hormones with a profound effect on the immunosuppression or the reduction in the resistance against infection or against infection from invading pathogens. For the examples of our glucocorticoids, we have the cortisol, corticosterone, and cortisone. So depending on the species, some animals have a predominant corticosterone, and while a majority of the mammalian species have a predominant cortisol as the major glucocorticoid in the body. So another zone of the adrenal cortex is the zona reticularis. The main function of the zona reticularis is to produce androgens. Now, aside from androgens, it also produces estrogen and progesterone. So this, of course, androgen will stimulate masculinization. And an example of this is the dihydroepiandrosterone or the testosterone. So just to review or just to recap the different steroids that are being produced by the adrenal gland, the endogenous ones as well as the synthetic ones. So for the cortisol, so this is the average plasma concentration in a microgram per 100 ml. So this figure considers both the free and the bound form of cortisol that is present in the plasma. In terms of its glucocorticoid activity, how do we interpret this number? So this number here represents the glucocorticoid activity of cortisol. This number here represents the mineralocorticoid activity of cortisol. So basically, the glucocorticoid and the mineralocorticoid activity of cortisol is the same. The ratio is 1:1. For the another type of glucocorticoid is corticosterone. So according to our reference, it is under the glucocorticoid group of hormones. But in this figure, you can see that the mineralocorticoid activity of the hormone corticosterone is higher than its glucocorticoid activity. Another hormone of the adrenal gland is the aldosterone. So when we say aldosterone, that is the principal mineralocorticoid in the body. So as you can see here, the mineralocorticoid activity of aldosterone is very high, no, at 3,000, as compared to its glucocorticoid activity, which is only 0.3. So that we can say that the glucocorticoid activity of aldosterone is negligible, no, as compared to its mineralocorticoid activity. And what could be the basis of this number? Now, 3,000, 15, 0.3, 0.3, 0.2. So the basis of this figure is our cortisol. So that is the basis of our number here, yung ating cortisol. So this means that, for example, for aldosterone, its mineralocorticoid activity is 3,000 times. 3,000 times compared to the mineralocorticoid activity of cortisol. Its glucocorticoid activity, on the other hand, is 0.3 times less, or 0.3 relative to the 1.0 glucocorticoid activity of cortisol. So ibig sabihin, the glucocorticoid activity of aldosterone is lower compared to that of cortisol. So the basis of these numbers is our cortisol, which is our major glucocorticoid in the body. So it has been considered as the basis for this because it has a relatively the same glucocorticoid and mineralocorticoid activity. For the deoxycorticosterone, the mineralocorticoid activity of the oxycorticosterone is 100 times. It is 100 times more potent than cortisol, but it is not as potent as cortisol in terms of its glucocorticoid activity. So for the dehydroepiandrosterone, which is an adrenal steroid, take note that it does not have a glucocorticoid or mineralocorticoid activity. For the synthetic steroids, so one of the most common synthetic steroids that we are using are dexamethasone. So dexamethasone does not have a mineralocorticoid activity. It only has a glucocorticoid activity. For prednisolone, so prednisolone has both glucocorticoid and mineralocorticoid activity, but its glucocorticoid activity is 4 times more potent than cortisol. This particular corticosteroid or synthetic steroid is being used as a replacement for glucocorticoid therapy. Now, in patients having a deficiency of or in patients now having, for example, hyperadrenocorticism or hypoadrenocorticism. So these are the examples now of our synthetic steroids now that we are using in treating patients with deficiency or excesses in cortisol or other hormones now that are being produced by the adrenal gland. So again, when we say mineralocorticoid activity, that is the activity of the hormone. That is the activity of the hormone to maintain the salt and water balance. For the glucocorticoid activity, that is the activity of the hormone to regulate the glucose metabolism. So in terms of its glucose activity, the corticosteroids increases the glucose activity, so it can cause the buildup of glucose in the blood or hyperglycemia. it also has an immunosuppressive activity. So when we say glucocorticoid activity, it also encompasses the immunosuppressive activity of our hormone, glucocorticoid hormone. So let's now proceed to the regulation of the aldosterone secretion. So when we say aldosterone, no, that is the major mineralocorticoid that is being produced in the body. Okay. So for the regulation of the aldosterone secretion, one of the major mechanism in the body, that will regulate the secretion of aldosterone is the RAAS system. So when we say RAAS system, RAAS stands for renin, the R stands for renin, A stands for angiotensin, the other A stands for aldosterone, and this is one of the long-term mechanism for the regulation of aldosterone secretion. So this is defined as a hormone system within the body that is essential for the regulation of blood pressure and fluid balance. So when we say fluid balance, that has to do with the regulation of salt and sodium in the body, as well as potassium. So the system is comprised of three hormones. We have renin, angiotensin 2, and aldosterone. So this is the figure showing the interaction between the different organs in the body, particularly the liver, the kidney, and the adrenal gland, as well as the lungs and all the other organs such as the arterioles, the pituitary gland, the hypothalamus, and others, in order to maintain the blood pressure and the salt and water balance in the body. So it all starts with the kidney. So basically, in the presence of a specific stimuli, a certain stimuli, such as the decrease in blood pressure as well as the decrease in renal perfusion. So this will trigger the juxtaglomerular apparatus of the kidney. So saan ba natin matatagpuan itong ating juxtaglomerular apparatus? Saan banda? Where can we find this juxtaglomerular apparatus? Anyone? Saan natin ito matatagpuan yung ating juxtaglomerular apparatus?
Kidney po, Doc.
Okay, saan banda doon sa ating kidney?
Sa nephrons po.
Okay. So we can find this juxtaglomerular apparatus in the nephron, particularly adjacent to our glomerulus. Okay, tinawag siya na juxtaglomerular apparatus. So one of the functions of this juxtaglomerular apparatus is that it will sense the changes in the renal perfusion as well as the changes in the sodium ions that are being delivered to the nephron. So when we say renal perfusion, it has to do with the blood flow, the blood flow that comes in towards the nephron. So when there is a decrease in the renal perfusion and there is a decrease in the blood pressure and decrease in the sodium ions, This will trigger the juxtaglomerular apparatus to stimulate the kidney, to produce the hormone renin. In the presence of renin in the bloodstream, this will also trigger the liver to produce a substance, a plasma protein known as angiotensinogen. So angiotensinogen will be converted into a peptide, angiotensin 1 in the presence of renin. This angiotensin 1 is a peptide consisting of 10 amino acids, and in the presence of a certain enzyme known as ACE. ACE stands for angiotensin converting enzyme. This substance or this peptide will be converted into the angiotensin 2, which is a hormone. The ACE or the angiotensin converting enzyme comes from the lungs and the kidney, particularly the surface endothelium. The surface endothelium of the pulmonary and the pulmonary and the renal endothelium. So the presence of this particular enzyme is very important because it is the one that will be responsible for the conversion of angiotensin 1 to angiotensin 2. So the angiotensin 2 is active substance. It is a hormone that will be responsible to act on different types of tissues containing the angiotensin 2 receptors. So for example, in the autonomic nervous system, it will stimulate the sympathetic activity. So it has a stimulatory activity to the sympathetic nervous system. So the broken line, a blue broken line here represents a stimulatory effect or a stimulatory signal to the tissues containing the angiotensin 2 receptor. So when we say sympathetic activity, just remember the fight or flight, meaning that those are the activities that will govern the fight or flight. Now, for example, in the heart, it will govern the increase in the heart rate. And in the lungs, it will govern the increase in respiration. And in the pupil, for example, it will induce the dilation of the pupil. Of course, one of its most important function, this angiotensin 2, is it will act on the kidney, particularly on the proximal convoluted tubule to reabsorb water. So reabsorption of water is done through reabsorption of sodium in exchange for potassium. So the water goes into the blood, the potassium ions goes into the urine or the glomerular filtrate. For the angiotensin 2, for the adrenal gland, the angiotensin 2 will act on the angiotensin 2 receptor in the adrenal cortex so that the cortex can produce the mineralocorticoid aldosterone. So this aldosterone will also act on the kidney to reabsorb sodium and to retain water in the body. Angiotensin 2 will also act on the arterioles, in the systemic arterioles, to induce vasoconstriction. So when there is vasoconstriction, there will also be unexpected increase in the BP or the blood pressure. Angiotensin 2 will also act on the angiotensin 2 receptor in the hypothalamus to induce thirst and encourage the consumption of water. In the posterior pituitary or the neurohypophysis, angiotensin 2 will act in order to produce the hormone antidiuretic hormone or vasopressin. So from the name itself, this particular hormone will be important to reduce diuresis or to retain water. So this ability to reabsorb water or to retain water is done through its action on the collecting duct of the nephron. Collecting duct of the nephron, so what it does in the collecting duct is that it will reabsorb water. So all in all, these activities will retain water and salt in the body due to the sympathetic activity. The effective circulating volume will also be increased. So because of the retention of water in the blood, so pag ma-retain yung water, mag-increase din yung volume, the plasma volume or the blood volume in the body. The perfusion of the juxtaglomerular apparatus will also be increased, so that the original stimuli, which is a decrease in the renal perfusion or reduce in the blood flow towards the kidney, will also be corrected. So in the presence of this effect, so this is so we can say that this is a long-term mechanism in order to correct the original stimuli or the underlying abnormality, which is the decrease in the blood pressure. So this is the interconnection between the renin-angiotensin-aldosterone is a long-term mechanism whereby the body will be able to correct the reduction in the blood pressure. So in the presence of this, in the increase in the salt in water retention, in the correction of the blood volume, as well as the correction of the blood pressure, this particular factor will send a negative feedback. Now, this red line here means that it is an inhibitory signal. It will send a negative feedback to the kidney, so that the kidney will not be able to produce further renin in the body. This is also another diagram showing the interconnection between the kidney, the liver, and the adrenal gland in the RAAS system. So again, our main stimuli is low blood pressure that is induced by the low sodium ions in the blood. So this will again stimulate the kidney or the juxtaglomerular cells to produce renin. And this renin will be important to convert the angiotensinogen, which is a plasma protein from the liver, to angiotensin 1. The angiotensin 1 is a peptide. It will be converted to angiotensin 2 by ACE. ACE stands for angiotensin converting enzyme. ACE is found or comes from the lungs and the kidney, and it will be responsible for the production of angiotensin 2. So in the adrenal cortex, angiotensin 2 will act on the angiotensin 2 receptor to produce aldosterone. So aldosterone in return will induce the reabsorption of sodium as well as chloride in exchange for the secretion of potassium ions in the lumen of the proximal convoluted tubule. So this activity in the kidney will increase the sodium and decrease the potassium in the blood or in the serum, increase the blood volume. So because again, there is the reabsorption of sodium. So because there is a reabsorption of sodium, so water will also be reabsorbed so that there is an increase in blood volume and ultimately increase in the blood pressure. So this factor will again send a negative feedback to the kidney so that the kidney will not be able to further produce the hormone renin. For the adrenal medulla is the part now of the adrenal gland that is basically responsible for the formation of the catecholamine hormones. So when we say catecholamine hormones, these have the general effect of preparing the body for fight or flight. In the fight or flight mechanism is under the sympathetic nervous system. So examples of our catecholamines are we have epinephrine, norepinephrine, and dopamine. So for the pathways of the catecholamine biosynthesis, so it all starts with the amino acid phenylalanine. So phenylalanine, for example, will be converted to L-tyrosine in the presence of the enzyme phenylalanine hydroxylase. And again, this enzyme or this compound will be converted to another form, L-dopa, dopamine, norepinephrine, and epinephrine. So when we say epinephrine, the other name of that is adrenaline, and it is the major hormone or major neurotransmitter that is responsible for the adrenaline rush during the fight or flight mechanism. So this particular activity is under the sympathetic nervous system. We also have different diseases associated with the adrenocortical hormones. And we'll start with the hyperadrenocorticism or the Cushing's syndrome. So when we say hyperadrenocorticism, that is refers to any cause of elevated cortisol concentrations in the blood. There are two forms of the hyperadrenocorticism. It can be due to the abnormality in the pituitary gland, or it can be also due to the abnormality in the adrenal gland itself. So the pituitary-dependent hyperadrenocorticism, which is also known as the PDH, and Cushing's disease. And the PDH, or the pituitary-dependent hyperadrenocorticism, is considered to be the most common form and accounts for about 80 to 85% of the reported cases. The other one, which is the adrenal origin, occurs when a unilateral or bilateral adrenal tumor secretes cortisol and accounts for 10 to 15% of the cases. So majority of the reported cases are those that are being caused by the abnormality in the pituitary gland. So just to have a differentiation between these two terms, when we say Cushing syndrome, this refers to the elevated adrenocortical hormones, regardless of the cause. When we say Cushing's disease or PDH, this refers to this particular disease arises from adenomatous enlargement of the pituitary gland, resulting in excessive ACTH or corticotropin production. So therefore, when we say Cushing's disease, this is limited to the tumors that are present in pituitary gland, while Cushing syndrome could either refer to an elevated glucocorticoid secretion that can be due to the tumors present in the adrenal gland or tumors present in the pituitary gland. For the clinical findings, so this particular endocrinopathy is most common in middle-aged to older dogs, 7 to 12 years old. And again, it is more common. The more common type is the PDH, or the pituitary-dependent hyperadrenocorticism. So these are the breeds that are show sensitivity to hyperadrenocorticism. And these are the different clinical signs of the hyperadrenocorticism. So we have polydipsia. So when we say polydipsia, it refers to thirst, increase in thirst. As we have earlier mentioned, one of the function of the RAAS system, Renin-Angiotensin-Aldosterone System, is that it will stimulate the hypothalamus to the action or the binding of the angiotensin 2 to angiotensin 2 receptor will stimulate the hypothalamus or will induce thirst and increase the retention of water, or increase the encourage the intake rather of water. So there is a polydipsia because of that. Increased thirst, polyuria, or increase in urination, polyphagia. Polyphagia because, again, the glucocorticoid, cortisol, has a main effect on the metabolism of glucose. And also heat intolerance. Lethargy, and abdominal enlargement of the animal and pot belly. And these are the other clinical signs of the hyperadrenocorticism. There is muscle weakness, UTI, recurrent UTI, alopecia, thin, fragile skin, especially in cats, and pyoderma. For the serum chemistry, so some of the parameters in the blood that can be seen when there is hyperadrenocorticism are increase in the SAP, or the serum alkaline phosphatase, and increase in the ALT, or the alanine aminotransferase. So these two enzymes, the increase in the blood levels of these two enzymes, alkaline phosphatase and the alanine aminotransferase, will indicate that there is an abnormality in the liver. There is also hypercholesterolemia, or the increase in the level of cholesterol in the blood. So as we have earlier mentioned, one of the function of the cortisol or glucocorticoid is that it will induce lipolysis. So when there is increase in lipolysis, so there is also an increase in the breakdown of lipids into fats and cholesterol. So there will be a buildup of cholesterol in the blood. There is also hyperglycemia. So cortisol has a sparing effect on the glucose. So it has a opposite effect to that of the insulin, because insulin will facilitate the glucose uptake by the cells. Meanwhile, the glucocorticoid will spare glucose. It will inhibit the action of insulin, and it will also increase gluconeogenesis, or the production of glucose from non-carbohydrate sources. So there will be an increase in the glucose in the blood, resulting in hyperglycemia or the increase in the blood sugar. There is also a decrease in the blood urea nitrogen. So one of the manifestations of the hyperadrenocorticism, especially for those patients having kidney disease, is that there is an increase in the blood urea nitrogen as well as creatinine. For the diagnosis of the hyperadrenocorticism, this includes so these are the bases in evaluating the hyperadrenocorticism. So first are the appropriate clinical signs that is associated with excess glucocorticoid or excess cortisol in the body or excess mineralocorticoid, followed by supporting database abnormalities such as high cholesterol and SAP or the serum alkaline phosphatase, and confirmed via screening test. For the preferred diagnostic test to diagnose hyperadrenocorticism, so this includes the low-dose dexamethasone suppression test or the LDDS. So as we have earlier shown, dexamethasone is a synthetic preparation of glucocorticoid. So administration of this particular synthetic steroid or exogenous steroid in a low dose manner is one of the preferred diagnostic tests for hyperadrenocorticism. So for the treatment of CD or the Cushing's disease in dogs include medical therapy, including methylene, trilostane, radiation therapy, and surgery, or hypophyseectomy. For the prognosis of dogs with PDH, or the pituitary-dependent hyperadrenocorticism, has been estimated to be 2 years. Then radiation treatment of the pituitary tumors or hypophyseectomies is associated with a long-term prognosis that is about 2 to 5 years. Prognosis of dogs with unilateral adrenalectomy was about 18 months. So another abnormality that is associated with adrenocortical hormones is the canine hypoadrenocorticism or the Addison's disease. So this is more common in dogs. That is why it is also known as canine hypoadrenocorticism. So this is a deficiency in adrenocortical hormones that is seen most commonly in dogs, young to middle age, as well as occasionally in horses. These are the breeds that are predisposed to Addison's disease. And for the causes, so one of the most common cause of the hypoadrenocorticism is due to the autoimmune process, so meaning it is mediated through the immune system of the animal. So in this type of disease, the immune system of that particular animal will destroy the cells of the adrenal gland of that particular animal. So from the word auto, meaning self, and the immune process, meaning that the cells of that particular animal will destroy the immune system, rather, of that particular animal will destroy its own self or own cells. So this results to the destruction of the adrenal gland by granulomatous disease, metastatic tumor, and hemorrhage. So due to the destruction of the adrenal gland, so that will cause the inability of the gland to produce sufficient amount of the hormone, glucocorticoid and mineralocorticoid. So in Addison's disease, there is an inadequate production of the steroidal hormone, mineralocorticoid, and glucocorticoid within the body. So it follows destruction of the adrenal cortex of the adrenal gland, usually from an immune-mediated process. So again, the mineralocorticoids are important because it will maintain the normal blood volume, it will maintain the normal cardiac output through its activity through the sympathetic activity, and it will also maintain the water and electrolyte balance. For glucocorticoids, the cortisol is a glucocorticoid that gives an animal the ability to respond to stress. So cortisol is a stress hormone, and the presence of cortisol in the blood can indicate that the animal is in stress. So the higher the amount of cortisol in the blood, it also suggests that the animal is being exposed to a higher level of different types of stressors. Now, it could be mechanical, it could be physical, it could be environmental, or it could be uh, emotional, emotional stressors. So due to the abnormalities or the clinical findings that are associated with the Addison's disease has to do with a deficiency of these two types of hormones. So for the clinical findings, signs are considered to be vague. These may wax and wane over time, and they are rarely pathognomonic and may be present for days, weeks, or months before the diagnosis. So this particular disease or endocrinopathy has been referred to as the great pretender due to its inability to mimic other common diseases in the dog. So its clinical signs are not specific, so that it's most of its clinical signs resembles the other common diseases. So what are the symptoms of the Addison's disease? For the acute presentation, there could be vomiting and diarrhea. There can be a severe dehydration. Okay, severe dehydration to the animal. There is shock, and there is slow in heart rate. So this is associated with our deficiency of our glucocorticoids. So for example, severe dehydration is due to the lack of aldosterone. So as we all know, aldosterone is important for the reabsorption of water, reabsorption of sodium, and also in the heart rate, because the aldosterone will maintain the heart rate through its activity uh, to the arterioles, as well as its activity with um, the angiotensin, its activity to the sympathetic nervous system. For the chronic presentation, again, these are non-specific. So there is weight loss, there is trembling, hypothermia, weakness, collapse, anorexia, lethargy, diarrhea, excessive drinking. Okay, there is excessive drinking because of dehydration and excessive urination. Excessive urination because this is associated with bakit kaya merong excessive urination dito sa Addison's. So what could be the cause of this? Bakit kaya merong excessive urination? So why do we have this particular presentation here, yung ating excessive urination? What could lead to this? Kaya yung factor why there is excessive urination in Addison's disease? Any answer? Any
Kasi po,
volunteer?
Doc, there is a decrease in secretion of mineral corticoid.
Okay. So mineralocorticoid yung ating aldosterone. No? So and also one of the possible factor is that 'di ba yung sa ating RAAS system? Okay. Tama ito no yung sinabi ni uh, Mr. Gleo. There is it could be associated with the decrease in the production of the antidiuretic hormone. No, because when there is an abnormality to the system of the RAS, there could be a decrease on the antidiuretic hormone. So one of the function of the antidiuretic hormone is to uh, retain water in the body. And also, di ba yung antidiuretic hormone, it will retain water, it is antidiuretic. So that in the absence of this particular hormone, so there will be a continuous excretion of water in the body by urination. So yung excessive drinking, of course, that is associated with yung ating excessive drinking due to ano nga yung cause niya? Dehydration. No, dehydration. Dehydration due to excessive urination. Hypothermia because again, glucocorticoid is a metabolic hormone. No, just like the thyroid hormone, so metabolic hormone siya. So there will be not enough hormone that will maintain thermogenesis. There's also weight loss because the deficiency of the glucocorticoid hormone there will be not enough hormone that will induce will boost the appetite of the animal. Because diba yung glucocorticoid, one of its function is to boost appetite, to increase the intake of glucose in the blood. To increase the intake of glucose. So for the diagnosis of the Addison's disease, so ACTH stimulation test can be done in dogs. The step 1 of the ACTH stimulation test is blood collection. So we must obtain a plasma or serum sample or baseline cortisol levels within the body. The second step after blood collection is through IV injection of cosintropine. So what is this cosintropine? So cosintropine is a synthetic form of the hormone ACTH. Step 3 is the blood collection after injection of the cosintropine. So obtain plasma or serum sample for cortisol measurement 1 hour later. So as we all know, the ACTH is a hormone that is produced by the AP, anterior pituitary, to stimulate the production of cortisol and other adrenal steroids from the adrenal gland. So in this case, in the ACTH stimulation test, so what is being done is that an exogenous preparation of ACTH will be administered in the form of cosintropine. And after 1 hour, blood will be collected. And when there is no improvement in the level of ACTH in the blood, so that could possibly indicate that there is the presence of hypoadrenocorticism. So again, ACTH is produced by the anterior pituitary in response to stress, and cortisol is produced by the adrenal gland. So what ACTH will do is that it will stimulate the adrenal cortex to produce the cortisol. Damage to the adrenal gland will interfere with the production of cortisol. So ACTH is not able to stimulate the adrenal gland to produce cortisol in patients with hypoadrenocorticism. So that is why there is no improvement in the cortisol level. So this is another representation of the ACTH stimulation test. No, so for those patients having a normal functioning or normal function of the adrenal gland, so the concentration, the plasma concentration of the cortisol is normal or increasing after the administration of exogenous ACTH cosintropine. So there is an increasing level of cortisol after ACTH injection. So because again, ACTH will stimulate the production of cortisol. For patients having Addison's disease, so take note that there is no movement in the level of cortisol in the blood. So the baseline plasma cortisol levels are extremely low and do not increase after the ACTH injection. So how can it be treated? So the first thing that should be done is to correct the low blood pressure and correct the low blood volume. So again, these are all associated with a deficiency in the hormone aldosterone. So there is low blood pressure and the low in the blood volume. Again, is to provide glucocorticoid and possible mineralocorticoid replacement. So our glucocorticoid replacement here is prednisone. So prednisone is a synthetic glucocorticoid tablet that can be that can serve as a glucocorticoid replacement. Again, the other means for treatment are to restore the electrolyte balance and to restore the acid-base balance. So this can be done through the fluid therapy. So we have here example of a patient with the Addison's disease. So her name is Daisy. This is a 6-year-old Maltese, and for its history or its background, Daisy was previously diagnosed with Addison's disease for 4 to 5 years. So upon presentation, Daisy presented this initial clinical findings. So there is bloody diarrhea, there is vomiting, there is tremor, and there is lethargy. For the medical management that was instituted by the IVS, or the Iowa Veterinary Sciences, so they administered dexamethasone, SP. So this is a synthetic steroid used to replace the glucocorticoids within the body, dexamethasone. Serenia, so Serenia is a drug that will be used as an anti-nausea to prevent further vomiting. We also have metronidazole. This is an antibacterial medication to help with Daisy's diarrhea. So when you say metronidazole, where do you usually use that in humans? Ano natin ginagamit yung metronidazole?
Sa may mga parasitic infections.
Particularly, anong parasitic, anong parasite? Anong parasite yun? Diba there are many types naman of parasites? So metronidazole, we use that for protozoa, yung mga protozoa such as amoeba, amoebiasis, trichomoniasis, and giardiasis. So aside from its antibacterial activity, it is also very important to treat protozoal infection. Vet starch to help support the low protein levels in the blood. So this condition requires continued medical management. So the treatment is lifetime. Oral medications daily of glucocorticoid to replace the deficiency in glucocorticoid. Injections are monthly with mineralocorticoid. Then Daisy will also require periodic checkup from her regular veterinarian throughout her lifetime. So after multiple days in the hospital, Daisy was able to make a full recovery. So the treatment of Addison's disease, since it is immune mediated in nature, so the treatment is usually lifetime. So just to touch na yung ating those drugs that will interfere with the production of the angiotensin 2. So can you name that particular drug that will interfere with the production of the angiotensin 2? Have you encountered that drug or that particular drug that will interfere with the production of the angiotensin 2? So angiotensin 2 is an important factor that will stimulate the sympathetic activity. It will increase the blood pressure. So there are certain drugs that will inhibit the production of angiotensin 2, and that will be important for the treatment of high blood pressure. So we have those particular drugs that are important to inhibit the formation of the angiotensin 2 from angiotensin 1. So again, angiotensin 2 is important for the production of increase in blood pressure, hypertension, and water and salt retention. So anong pangalan ng mga compounds na yon? Those drugs that will block the formation of angiotensin 2 from angiotensin 1.
ACE inhibitors po, Doc.
Okay, so those are the ACE inhibitor or our angiotensin converting enzyme inhibitor. So pag ma-block itong ACE inhibitor, ACE due to the action of the ACE inhibitor, so the formation of angiotensin 2 from angiotensin 1 will not happen. No, so that this ACE inhibitor, no, such as yung ating captopril and other drugs, they are indicated for the treatment of hypertension. But we should not confuse this with other types of drugs that will also treat hypertension, such as losartan, we also have our beta blockers, no, such as propanolol, pindolol, nadolol. Those drugs having a suffix that ends in LOL, now those are considered as beta blockers or beta receptor antagonist. And saan nga natin matatagpuan itong ating mga beta receptors? Saan natin ito sila matatagpuan?
Sa heart po, Doc.
Okay. So majority of our beta 1, because there are 3 types of beta receptors, yung beta 1, 2, at saka 3. Yung beta 1 is found in the heart, beta 2 is found in the lungs, beta 3 is found in the adipose tissue. So yung beta 1, ano yung kanyang biologic activity? And it's agonist. Ano yung biologic activity ng beta 1 at saka yung kanyang agonist?